Hospital. He's board certified by the American Board of Orthopedic Surgery, and his prior experience has been as the director of scoliosis and spinal deformity at Valley Children's Hospital in Fresno, California. He's also director of pediatric orthopedics at the Naval Medical Center in Virginia. He attended medical school at the F. Edward Hebert School of Medicine, Uniform Health Services of the University of the Health Services in Bethesda, Maryland. He completed his residency in orthopedic surgery at the National Naval Medical Center in Bethesda. Dr. Elliott then did a fellowship in pediatric orthopedics and spinal deformity at Rady Children's Hospital in San Diego, California. He is speaking today on how many fractures is too many, bone health in the pediatric patient. Welcome, Dr. Elliott. Thank you.
Well, thank you for the introduction. Give me a minute here while I try to set up share screen. Let's see. Okay.
It's coming in, great.
All right, I'm going to turn off my video while I lecture, if I can figure out how to do that.
Oh, I can do that for you.
Oh, wait, I found it. Okay. And there we go. So this lecture really became interesting to me because this is a question I get routinely in my practice. In fact, I just got this question before I went on vacation last week. As a child's had 2 different fractures, and should they have a bone density study done? And is this too many? Is there something wrong with their child? So that's really what prompted me to want to do this lecture and talk about pediatric bone health. So I do have disclosures. I'm an educational consultant for orthopediatrics because they will hire me to do lectures for residents. All right, so why do kids get fractures? Well, you know, this is varied into and a very complex question, but if you look at these photos and see what these kids are doing, you should answer yourself, well, of course kids get fractures. They wreck on their bikes, they fall off monkey bars, and my favorite, the trampoline, lands many kids in my office. So the question is, you know, how do you figure out which of these fractures are abnormal? Okay. First of all, kids get fractures for the multiple reasons, and a lot of it is behavior. Kids tend to be some risk takers. A lot of children crave excitement. And a big one is they really don't have a good understanding of consequences. If you look at this photo on the right, you can see that what looked like it was going to be an exciting, good idea is probably going to turn out very poorly for the last guy in this photo as he really starts to realize and understand the consequences of what's going to happen. More importantly is by 16 years, 40% of girls and 64% of boys will have at least 1 fracture. And after you get 1 fracture, there's a 23% chance of getting a second one. I get the question, and I'm sure all the pediatricians do on a routine basis, even after 1 fracture, is there something wrong with my child's bones? Should we do a workup? Or is this just normal kid stuff? So I think the biggest thing is you have to understand not all fractures are equal. The first question I'll ask is, you know, what's the mechanism of injury? How did you do it? They tripped over a column curb and fell on their wrist, and then their arm hurt, so they were brought in and got x-rays. So I'm looking then at, like, was it a large bone or a small bone? And when I say a large bone, we're talking about femurs and tibias mainly, or your spine. Versus a small bone, it could be an elbow, a wrist, fingers, and how many fractures have they had in the past? So common fractures This is probably the most common fracture, which is a distal radius, and this is a buccal fracture. So basically, these kids I would treat in a cast versus a brace because you can't take a cast off. And it's not that this won't heal fine on its own, but if the child falls again, it may turn it into something that's operative. Another common fracture that looks really bad, but actually is common, is breaking both the bones in your forearm and the shaft. Again, these are treated with casts and by themselves. If I saw both these fractures years apart, I really wouldn't think anything of it. Or if they also had an ankle fracture. Now, if they had all three of these, I might start wondering and thinking more about, is there something causing this? Is there something in their diet? Or do they have an underlying metabolic problem? So I guess a lot of what the pediatricians ask me is, well, how do they know which ones are bad and which ones aren't? Well, we need to talk about what I call suspicious or abnormal fractures. And this is from Young Frankenstein, and this is Igor getting an abnormal brain. So we saw what some of the common fractures are. So we need to talk about uncommon things. These are the things that will spur you to do a workup. Okay. So these are long bones. So the child on the right tripped over a curb, landing on the curb, and broke his tibia. That by itself is reasonable, non-displaced, needs a cast, not a big deal. 6 months later, he falls, jumps off the couch and breaks his femur. All of a sudden now I'm thinking, is there something going on with this child? That mechanism shouldn't break your femur. It can, but once you have two long bone fractures like that, that's when you really need to be concerned that there's a problem and possibly a problem with bone health. So a good way to say, well, how do I know what low impact energy is? Think of low impact as falling from a standing height, tripping over a curb, falling off one step, going down out of your front door. Those are pretty low energy mechanisms, falling off your bicycle versus jumping your bicycle off a 10-foot ramp and flipping it. That's high energy. So you want to break that down and go, okay, low injury, high injury, big bones, little bones, and you start to get an idea that there could be a problem for these children. So the workup. Well, x-rays we all get. A child comes in, and how do I decide if I'm going to x-ray him and it's not just an ouchie? Well, what you do is you push where they say it hurts on the bony prominence, and if they hurt a lot, then I get an x-ray for sure. If they go, well, that doesn't really hurt, I may not x-ray him and just decide. Now, I'm under a different legal standard than pediatricians, so if you come to my office, there's a good chance you're going to get an x-ray. But I would never fault a pediatrician who palpated everything, the kid was non-tender, and not x-rayed them. So the big question is Dexa scans. Then we have laboratory endocrinology and genetic testing. We're going to get to all that stuff. Dexa scans is this thing that all parents know about. They get on the internet and find out that, wow, I can find out what my kid's bone density is. The question is, are they really helpful? I'm not a big fan of them. What a Dexa scan stands for, and you can also see it written as DXA, is the abbreviation for it. It's dual energy radiographic absorption metry. So the problem is it's not really a 3D evaluation, it's in 2 dimensions, and you can get a low bone mineral density in people that are short. The other issues you have is kids that are at different pubertal stages and bone ages. So for instance, if you look at standards for a 13-year-old, but their bone age is really 11, you may be getting false readings from that. And I'm sure everybody knows what a T-score is. I didn't. But a T-score gives you the standard deviation based on what a normal adult would be somewhere between 26 and 30 years old. So it is completely not applicable and is not reliable in children. What you have to look at are Z-scores. And Z-scores are where you actually look at those scores correlate to someone of the same age, the same pubertal, and the same bone development. They should also normalize them for height and weight. And these are standards that are put out by the company. and we're going to go over why that's important. And usually if you have a score less 2 standard deviations or -2, you may be a risk fracture for low bone density. They don't call it osteoporosis, it's low bone density, and that's a standard now that's accepted. So the biggest problem is you're going to order this and a child has a -2, so they may have low bone mass for their age group. It's all been correlated, but now what are you going to do with this information? So, you know, how's that going to affect your management? And I'm sure all of us, and I specifically did, had an old mentor who went through this and said, never order a test, Mike, unless you know what you're going to do with the result, or don't order a test because you may get an answer you may not want. So if you order this study on a child thinking, oh, I'm going to show mom that the bone density is normal and it's not, now what do you do? Are you going to start them on bisphosphonates? Or are you going to restrict them from all activities? So it's really, I have not found it helpful unless I'm going to start a therapeutic intervention on a child. My endocrinology colleagues may differ with me on this. So who gets a Dexa scan? Well, kids, maybe have a low body weight, multiple fractures, who are on chemotherapy, who are on steroid therapies, young adolescent girls who have amenorrhea for more than 6 months is maybe a good person to get this on to see where they're lying and if there's an underlying problems, but you may actually get more answers with a different type of workup. A good example is I had a child in my office 2 or 3 weeks ago who had I presumed it was a Z-score of -3 because mom just gave me this written score. She didn't have the actual data for me to look at. She couldn't remember where it was done at, so I have no idea what that score really meant. So we looked at his films and I went over with her saying, yes, he may have low bone density. And then we talked about diet and nutrition, which I think is probably the most important thing. So again, when do you order a Dexa scan? Well, only order if you're going to use the information for an intervention. Kids with vertebral body fractures without high energy trauma, they may have a significant problem with bone density. And we're going to talk about this again as a risk factor for other problems. Or 2 kids that have 2 or more long bone fractures before the age of 10. May do it, but then again, you have to understand what are you going to do with this data once you get it. The other thing is, you know, when you're going to do this and you're going to do an intervention, you're going to get them on vitamin D and calcium and you're going to recheck them. Probably shouldn't recheck them until they're 1 year. And the problem with that is if the child grows, just growing and changing the size of his bone will make a difference in the reading. So it really becomes difficult to monitor these kids with this. You're also going to have parents that ask you is, well, how much radiation is that? It's actually pretty minimal. An example is it gives you 5 to 6 microsieverts, which is a physics evaluation of how much radiation you're getting. And don't ask me a question on that because I cannot explain it. You're going to need a physicist. But an example is just flying across the country in an airplane, you'll get 80 microsieverts of radiation just by being up at altitude. So it's actually pretty minimal. So I don't think that would be a reason not to order. More importantly is, what are you going to do with the information? So this brings us to the part, and I know all the residents have heard this. What do you do when you hear hoofbeats? Specifically in Nevada, look for horses. Don't look for odd things. Now, we just came back from Zion on vacation and we heard hoofbeats and it was a giant herd of elk running through a field. So, okay, but that's odd. For Nevada, look for horses, look for common things, don't look for odd things. Yeah. So when a kid comes with a fracture or, you know, and there's a problem, first thing is it normal trauma? Kids fall off bicycles, kids fall off climbers, kids fall off swings. I don't worry about it, but I do use that as my first step to look at nutritional problems. How's the kid eating? And then if I get warning signs through any of this, then we start thinking, should I do a metabolic or a genetic workup? Just remember, trauma is normal for kids and they do break bones. Okay, the nutritional history is a really important thing. Here's a slide that shows some little kids looking at different types of food. And once or twice a week in my clinic, especially at breakfast time, you can take any one or two of these items and the kids are going to be having them. A lot of times it's Takis and Gatorade. They may have really healthy fruit snacks that have number one ingredient is sugar, but the parents think it's made with fruit juice. So a lot of this is education for parents on nutrition. And I don't need to tell you guys about that. You're much better at it than I am. Specifically though, I look at what they're doing for calcium and vitamin D. And parents go, what can I do to get this fracture to heal faster? And I talk to them about their diet. Food logs can be heavy, can be helpful. But it's really important to remember, and I know you guys know this, but heavy children aren't always healthy children. Obesity and lack of exercise is really a contributing factor to fractures. So the kids nowadays that sit on the couch and play Call of Duty all day and then run out to get a Big Mac and trip on the curb and fall and break something, yes, that's a normal mechanism for that injury, but there may be other problems. It may be their nutrition. They aren't getting a lot of calcium. They aren't getting vitamin D, and they certainly aren't getting any exercise. And that has been shown to really decrease the number of fractures children get. But you can also make the argument that kids get fractures because they're out exercising, and they do. You see it from soccer. You see it sliding the bases at, baseball. But really the bottom line is we just got to make sure these kids are getting adequate calcium and vitamin D in their diet. So one of the biggest things, which you wouldn't expect, but I see a few cases every year, is nutritional rickets. And that's a vitamin D deficiency. Some of the risk factors are prolonged breastfeeding, can lead to it. A very strict vegetarian diet can give it to you. We see it a lot in immigrant populations. Specifically, when I was in Fresno, I would see it from children who were malnourished who came up from Mexico. Dark-skinned population, we also see it in malabsorption syndromes. Interesting, if you look at this photo, some of you it's a stock photo, you may recognize it, that this is from the 1900s, and the kids are getting spoonfuls of something. Well, actually, they're getting cod liver oil. I cannot imagine having to give that to a child today because there's no way they would take it. But Alfred Hess in 1900 gave cod liver oil to 65 infants with rickets, and 92% of them resolved. And this is what eventually led to adding vitamin D to milk and other foods. So it's really important. This was a real problem in the turn of the century, and it had a very simple solution, which was diet. So what do you see in nutritional rickets? Well, the radiographic findings, you see cupping of the physis, and it's usually pretty wide. And the reason is what happens is at your growth plates is the cartilage cells there proliferate. And then as they get closer to the metaphyseal section here, they start to ossify. Well, if you don't have enough vitamin D and calcium, this zone gets bigger and bigger and they don't ossify normal. Meantime, because they're not having a lot of calcium, parathyroid hormones kicking in and telling the bones to release calcium to help with other systems. And all of a sudden the bones start to get weak, and then you start to see pathologic fractures like this on the child's left femur. And it's usually significant bowing or fractures is when I see these kids and we pick it up. If it hasn't been picked up by their pediatrician, a lot of times it has been, and they're being treated when I see them for their bowing. The good news is treating it with vitamin D and calcium many times resolves a lot of these deformities. Okay, so here are recommendations from the National Institutes of Health for calcium intake. And I think the easiest thing, which I've gone over with my PA, is vitamin D. 1 to 3 years old is 600 units. 9 to 18-year-olds is 600 units. So pretty much I recommend 600 units every day. Now, the problem is you really have to make sure parents understand, as you guys know, that more is not always better. 1,200 milligrams of vitamin D could be bad, could be toxic. So you don't want to just keep giving them tons and tons. The other thing is the amount of calcium. And as you can see, as you get older, especially the 9 to 18-year-olds, is 1,300 milligrams. And I actually would extend that up into somebody in their 20s, 1,300 milligrams daily. The problem is, especially with adolescent girls, is getting them to drink that much milk or eat that much cheese. It's 4 glasses of milk. Now, the good news is for your lactose intolerance, a lot of almond milk and soy milk is all vitamin D fortified and actually has more calcium than regular milk. So when I see these kids with fractures, I really push nutrition for them. We talk about weight loss and we talk about exercise. Just jumping 10 minutes a day in place 3 times a week will increase their bone mineral density. So hopefully at some point we'll get to a 3D or virtual reality version of video games where the kids actually have to move around. And I think that will really help with a lot of these problems. So here's where all the medical students are probably going to groan. As I throw up this chart, this is really important. Here I am, 20-something years into my, after my training, and this is still important. So what happens is you get parathyroid hormone, which goes to your kidneys, right? And that causes them to hydroxylate the vitamin D to 125 hydroxy vitamin D, which then goes to the gut. You increase calcium absorption, your calcium goes up, it goes to the parathyroid hormone and turns it off. So when you start seeing breaks in that pathway, there's a problem. Not only is this going on, but the parathyroid hormone's going to the bones and turning on osteoclasts, which are breaking down the bone and putting calcium and phosphorus back into the system, because unfortunately, I don't like to really admit this, but there are more important organs than bone, such as your nervous system and your heart, which need calcium to function. Okay. So for the orthopedic surgeons that may or may not be in the audience, I always simplify it. Your bone is like Scrooge McDuck and calcium is gold, and you just want to hold it all. You don't want to give any up. Unfortunately, everybody else out there wants some of your gold, and they're going to do multiple things to try to get it away from you. Okay. Now we can talk about zebras. Zebras are really important. And this next slide is really going to illustrate what I think for me is the most important thing that I want you guys to never miss. Okay. So this is an 8-year-old who fell off of a swing and they have multiple spinal compression fractures. Okay, Dr. Elliott said multiple spinal compression fractures, that's osteoporosis. That's not the take-home message. Okay. And so if you can't see this, this square shows you kind of what the normal shape for a vertebral body is. That's a severe compression fracture. That vertebrae is compressed. That vertebrae is compressed, and that's compressed. Some of the lower ones are too. So this child has multiple compression fractures of their spine from a fall from the swing. That is abnormal no matter how you look at it. But I don't want you thinking low bone mineral density, because that's not what this girl had. This girl had leukemia. This is something we cannot miss. Now, the survival rates for leukemia now are over 95%. So I've been told by my hemonc colleagues. For ALL, when I started my residency, it was probably 65%. A lot of those kids died. It is so treatable now that this is something we don't want to miss. So if nothing else comes out of this lecture, multiple compression fractures in the spine, think leukemia. Simple screening test, CBC peripheral smear. If that looks okay, then you start looking for other causes. All right. So some of the other zebras, which I do see, but they're usually referred to me from endocrinology for Boeing, is things like hypophosphatemic rickets. It's about 1 in 20,000 kids. In Northern Nevada, we have about 120,000 kids. So there should be at least, 6 or 7 of these kids running around. I know I have 2 or 3 that I follow, and they aren't as bowed as this picture shows, but they do have mild bowing. So I'm watching them and they're being treated medically. I think the biggest thing is nobody expects you to be able to diagnose this, but if you see decreased serum phosphorus or low 125 vitamin D, then what I want you to do is you send them to the endocrinologist, because that's what I do. I don't manage this. I usually send it to endocrinology and have them help me manage it. And then once the child's on medication, if they aren't correcting, then I do surgery on these kids to get them back to where they need to be. Okay. Another one that's pretty obvious is renal osteodystrophy. But renal disease causes osteopenia in children and low bone mineral density, mainly because they aren't getting enough calcium because their phosphorus isn't being excreted. So it's coming in and it's keeping this ongoing loop of increased parathyroid hormone. Remember that slide I said you really thought you could forget in medical school? You still need to understand that, or at least understand it well enough to go, oh, this kid needs to go to see endocrinology to see if there's other things we can do to help them out. And they're already probably being seen by renal. Very rarely do I pick up a new kid in chronic renal failure. They usually come to me with things like, as you see here, a slipped capitofemoral epiphysis or fractures for treatment or angular deformities. Okay, so now we're going to kind of switch gears from our metabolic problem to osteogenesis imperfecta. So this is a genetic disorder, and this is where that genetic portion of my differential comes up. Does the kid have osteogenesis imperfecta? Well, this is a type 3 child. That's pretty obvious, and you know that right away. This is a child with type 3, but not as severe, but still wheelchair bound, multiple fractures. Now you have type 1s and 4s, which actually can be pretty normal. And both these kids have osteogenesis imperfecta, and you can see them walking around in this clinic. So that's why it's really important you start looking at how many fractures do they had. One of my osteogenesis type 4 patients probably saw me yearly for fractures. And a lot of these parents I'll teach how to put on splints themselves so they aren't coming to the ER every, once a month to get seen. They usually will splint them and call me and say, hey, Aiden's having bone pain. Okay, bring him in this week and we'll take a look and see, they don't always need operations. They usually need brief immobilization with a splint, not a cast, because remember, casts actually cause you to lose bone as well. So I tend not to immobilize them if I don't have to, and it's a very short period of time, and then we'll let them go. Now, some of you are going, oh, but there's 11 types of OI. There is. Silence has described the first 4 types, and now there are actually 11 types. 95% of them, they'll fall into types 1 through 4. So the rest, I think, is a genetics lecture. So it's important to understand that sometimes you'll see these kids with really awful looking x-rays. In fact, if you just looked at this x-ray and you didn't have any history, you'd be thinking, this kid has osteosarcoma. This kid has osteogenesis imperfecta, and he fractured and they get abundant healing callus. You also see stuff like this in neuromuscular kids. So those kids still do get cancers as well, but you also want to think, is this fracture healing normally? So most of them do heal with abundant callus. They heal fine, but their bone is weak and soft. And what happens is they get what's called microfractures. And the more microfractures you get, the more your bone bends and heals to the point it breaks and it won't heal anymore. And that's when you need intervention. And what intervention is, there's no way you can treat that because it's too bowed. So you actually cut the bone and realign it and put rods down it. And then they heal fine and get back to their level of normal activity where they're walking around. Now, bisphosphonates have really been helpful for some of these kids. It's really decreased the number of fractures they get, and it has also decreased bone pain for them. I've never used alodronate, but there are studies that show that it does the same thing. So just be aware of this. And these are kids that, we need to be careful of and mindful of, but we need to also keep them living as normal life as they can. The final zebra is idiopathic juvenile osteoporosis. I've had 2 kids in 20-something years of practice that actually I diagnosed with this. They come in with small buccal fractures, usually not big fractures. They have normal labs, but if you do a urine calcium on them, they're going to be in a negative calcium balance. So this is kind of the end of the road where you're trying to figure out what these kids have, and you're probably going to need help to find out if the kid truly has it. The most important thing to remember about these kids is that this is a diagnosis of exclusion. You need to rule everything else out first. This should not be the first thing in your mind. This is at the end, because it's more likely to be either just regular trauma, maybe rickets, maybe nutritional problems, could be renal disease. There's all the other factors you need to look at first. And once all those are negative and all the lab workup's normal, then you start thinking of idiopathic juvenile osteoporosis. So what's the workup? Well, for metabolic or nutritional problems, kind of the first stage is probably CBC, goes back just quick screen for leukemia, a complete metabolic profile, and 25-hydroxy vitamin D, and parathyroid hormone. I usually don't do urinary calcium excretion unless I'm getting towards the end of this and trying to figure out if it's juvenile osteoporosis. But by this time, I've probably consulted endocrinology too to have them look at it and see what else is going on. So this workup rule out nutritional, leukemia problems, metabolic bone disease, liver disease, renal problems, and parathyroid problems. Genetics is where you're going to rule out things like some of the metabolic problems, but are also genetically oriented, and osteogenesis imperfecta. And then endocrinology, some of the more obscure growth hormone problems. So it's more after I do some initial workup, then I start thinking, okay, do I need to consult genetics? Do I need to consult endocrinology for this? So what do I do? Okay, so large bone, small bones, how I'm going to break it down. On the right is small bone. So you've broken two small bones. So you have a buccal fracture in your distal radius. A year later, you now have a buccal fracture from a fall on your proximal radius, the radial neck. I just give reassurance to the family, and we talk about nutrition. I'm making sure they're eating fairly well. A lot of these kids, and I've seen it recently with some kids that were getting delayed unions that shouldn't, and grandma said, oh, their diet's horrible, and we put them on calcium and vitamin D, and sure enough, their fracture started healing. Would have healed anyway, probably, but you know, it's one of those things that I think it's a very simple thing for us to do. The National Institute of Health has a good handout for pediatric bones on this. It's a little verbose. I'm in the process of trimming it down to be more specific and easier. It's like 8 pages long, which is too much for parents. I try to keep things to 2 pages. And so eventually we'll have one of those, which I'll be giving all kids with fractures and anybody I think is at risk in my clinic. Now, if the parents really, really want to know and they're really pushing and need some confirmation, I'll go ahead and do a complete metabolic profile and probably 25-hydroxy vitamin D level just to look and see. If they come in with a third fracture, I might then go ahead and proceed over to the large fracture side. Now, large fracture, if you've had 2 large fractures before age 10, I do the whole laboratory workup. And once I look at that, then I start thinking, okay, you know, they fell off the swing, they, you know, fell down rollerblading, they broke their femur, broke their tibia. Okay, I'm more concerned with these kids. I think something else is going on. A great example was when I was in Fresno. I had a child come in with just a regular old ankle fracture, but really blue sclera. He was like 4. He just fell, and mom had blue sclera, and mom had a history of fractures, but they were never diagnosed. And I sent them to genetics, and I believe they came back with a osteogenesis type 4. Didn't change my management per se, other than education on fracture risk, and you know, went over with the parents so they keep breaking. You know, playing football is probably not a great idea. Let's look at some low collision sports and things like that. So remember, sometimes kids just fall down and break things, and just reassure parents that everything's going to be okay. You know, I can see maybe if you want to go a little bit further into this, if they don't believe you that their diet's terrible, you may have to try to do some things. You may want to do a Dexa scan to help with nutritional counseling. But again, if it comes back really abnormal, then you're going to be trying to figure out what do you do with that result. So I had 3 kids, 5 fractures, no workup. Thank you.
Does anyone have any questions for Dr. Elliott? You can put them in the chat, or you can turn on your video and unmute yourself. That was great. Thank you very much. It's a quiet group getting ready for our lunch break, I think.
Yeah, it's always sleepy time.
I have a question. I have a new patient with Osteogenesis Imperfecta type 1, and he is in adolescence. He's starting to have a whole bunch more fractures. Can you talk a little bit just about what's going on during adolescence that's putting him at higher risk?
It's probably his activity level more than anything. He's probably doing more aggressive sports. He's also trying to lay down more bone mass, but it's just weak. Usually at the end of adolescence, around 18, 19, they start tapering off. And I don't really know if that's because of they've started decreasing the amount of activity they're doing, such as jumping off fences or things, but these kids still want to be kids. I have one kid with type 1 who would go went body surfing and came back with a broken clavicle. And I said, Devin, of course you broke your clavicle. You know better. But, they want to be kids. So now there's not a whole lot you can do for it, really.
Okay, thanks.
Is there anyone else who had a question for Dr. Elliott? All right, well, that gives me a few minutes to get ready for the lunch breaks. So late yesterday, I think I figured out how that people can move themselves around, but I didn't tell my poster presenters we were starting till 12:20, so I don't even see all of them quite yet. So I'm going to put us on a little bit of a break, and we'll be back by 12:20.
Oh, yeah.
Into their breakout room.
We feel the same.
Dr. Holmes asked Dr. Elliott about child abuse.
Yeah, child abuse. Genetic testing is now really good, but that used to be the old fallback that, the kid has OI, because we really couldn't prove it 20 years ago. And that's what all the lawyers went to. Now it's pretty easy. I would tell you, if you have a kid as child abuse and there's any question, just send them to genetics, get the genetic testing done. It's usually pretty obvious. There's not a lot, child abuse, they have multiple fractures in different stages of healing. So if a kid comes in with a broken arm and 3 weeks later comes in with a broken tibia and they're under 2 and they're not taught, or they're just barely toddling around, I'd be very concerned about child abuse.
And Dr. Hardy is stating his grandson with OI and after years, no med treatment. What options do you recommend?
If he's not having recurrent fractures, I probably wouldn't. I think the IV pimidinate really did help a lot of the real severe type 3 kids. If they're type 1 or type 4 and they aren't breaking all the time, I don't know that I would do it. Everything carries a risk.
Okay, great. Anyone? Oh, we got just some thank yous and some great talks.